Good afternoon, everyone. My name is Kiyoshi. I'd like to express my deepest gratitude to all the committee members who prepared this conference. I'm so honored to be here and like to thank you all for being here. I have no financial relationship to disclose. Let's get started. Please look at this slide. This is what I will talk about today. First, I'd like to focus on the vertical correction with tags. Second, changing the perspective from the 2D to the 3D. Finally, 3D quantitative evaluation of the facial soft tissue morphology. At first, I'd like to show you this case report on vertical correction. It is published in 2018. The accuracy of the VTO was recommended from the past articles. Many doctors reported that VTOs can be useful in predicting the soft tissue profile changes resulting from the different treatment options. And that the actual result looked better than the prediction. Using the VTO, we compared 4 premolar extraction with non-vertical control and non-extraction with vertical control by molar intrusion. Here we show that non-extraction was more effective in improving the lateral profile. In the superimposition, the green arrow shows the counterclockwise rotation of FMA. And here is the actual result. Here again, in this case, we demonstrated the molar intrusion was more effective than premolar extraction. Please look at the pre- and post-treatment lateral photos. This article concluded that vertical control is a very important factor for influencing profile change. Please look at these two high-angle case reports as well. One is with minute screws, the other with mini plates. The intruded molars cause counterclockwise rotation of the mandible, and the anterior orbit improved. Posterior intrusion also improved the retrognatic profile by advancing pogonium. Please let me show you one of them. This is a summary of the pre-treatment record of the first case report. We used just two buccal minuscule to retract the anterior teeth and to intrude the molars at the same time. As shown in the table, you can see the patient's safe values. Lateral safe analysis indicated a skeletal class 2 with a hyperdivergent growth pattern. Her upper and lower incisors were proclined, and her upper molars had been extruded. A data setup was fabricated to determine the final occlusion because of the atypical extraction. These are extraction sites. As you know, a digital setup is much less time-consuming and easier to make. Once again, please check the final occlusion. These are post-treatment intraoral photos. The setup gave us results in line with our targets. Now I would like to demonstrate the VTOs of this patient. Here is a pre-treatment lateral photo. The upper first molar would be intruded 1.5 millimeter. Eventually, along with the intrusion of the molars, autorotation of the mandible took place. The upper first premolars and the lower left central incisor would be extracted. The upper and lower anterior segments would be retracted 5.5 millimeter and 0.5 millimeter, respectively. This is a prediction of the treatment without surgery. For your information, orthodontic surgery was also recommended for this patient. On the next slide, we have a prediction of the orthodontic surgery. This option was the two-jaw surgery involving the maxillary posterior impaction and the mandibular advancement. Pre-treatment. The upper first and lower second premolar would be extracted to resolve the crowding. To obtain autorotation of mandible and closure of the anterior open bite, maxillary or posterior impaction would be needed. Mandibular advancement surgery, along with advancing genioplasty, could be performed to improve the divergent facial pattern and at the same time move the chin forward. This is the VTO of the surgery case. This slide shows the comparison between the simulation of the component treatment and orthodontic surgery. This is her actual lateral view. Please compare it with the simulation images. However, please do not rely on the simulation too much. Sorry. This is a comparison of the lateral profile view. These are pre- and post-treatment lateral shapes. The values in green have improved. Please look at the highlighted area. In blue, the FMA value decreased by nearly 2 degrees. These are frontal view images. You can see the mentalis muscle strain was reduced. I have some updated information about the vertical correction with TATS. This article has been published recently. Please check the WFO journal. We introduced this device in this article. I'm sorry. This is a simple and effective design. It is good for the correcting the open bite as well as vertical control. The effect of the vertical control for the class 2 cases are more noticeable in developing patients. It is relatively simple to introduce by inhibited spontaneous eruption of the molars. With them, this treatment can be more effective than in the adult. For them, transpalatal arch with vertical headgear is often used instead of TATS. Here are the initial records. We used the transpalatal arch and headgear for 6 months before braces. Progress. These are post-treatment records. Here is a pre- and post-treatment comparison. Her lateral profile has totally improved. Please check the changes in FMA. Next case. These are pre-treatment records and post-treatment and 2 years retention. Here is a comparison of pre-treatment and post-treatment. Her lateral profile has much improved as well. FMA has decreased about 2 degrees. Let's go to today's second topic. Please change your perspective. In this part, I'd like to give you a different perspective. In other words, the methods I explained earlier are very effective in correcting the lateral view, especially in high-angle cases. However, the frontal view of the patient face tends to become rounder. Please look at the 3 lines. They show the height difference of the lateral and frontal profiles. The lower facial height has been reduced because of the auto-rotation of the mandible. Please check her frontal view. See the differentiation from the previous slide. These pictures also show the height difference of the profile. Do you agree that her face is getting rounder as well? What I want to say with the change of perspective is that normally we tend to focus on the lateral view. This time, I would like you to pay attention to the frontal view. I think some doctors will attribute this phenomenon to the growth of the developing patient. How can we find out what the real reason is? Let's review the first two cases we presented. Both cases already have completed growth. The phenomenon is more noticeable in these two cases. Of course, it doesn't happen in every single case. The maximum width of the face is shown by the green lines, which remain the same pre- and post-treatment. The lower facial height is shorter now due to the auto-rotation of mandible. As a result, her face seems to have become slightly rounder. Let's look at the next case. I mentioned earlier, her face also seems to have become slightly rounder as a result of decreasing the lower facial height. Perhaps you have some questions here. Number one, is the evaluation of the 2D facial photo reliable? Number two, how often does the facial rounding happen? Regarding the first question, as a more objective method of capturing facial morphological changes in 3D, the distance between the surfaces pre- and post-treatment was measured. This method measures morphological change for each individual patient. Now, let's look at some changes on several different patients. Some patients show the similar characteristics to those described above, while others only change a little. Please look at patient number 2 again. For this patient, we superimpose the pre- and post-OBJ data to calculate displacement. We confirmed the visual using the 5 mm scale. This way, we could more objectively show the patient's possible rounding effect than with the 2D facial photo, I mean the conventional 2D photo. The distance between the surface was measured by the HMB Google software. This is an example case. This patient had a low FMA. Here, pre-treatment record. And post-treatment, she underwent a 4 premolar extraction. Please look at this comparison. Does she change to a narrower frontal look? On the right, you can see the objective displacement. We use a 3 mm scale for this patient. The dark blue area has shrunk 3 mm or more. Here is another example case. These are the pre-treatment records. Her FMA is within the Japanese norm. And post-treatment, she also underwent a 4 premolar extraction. This is the comparison. Due to a severe crowding, achieving the facial change was a little bit hard. On the left are the OBJ data of the pre- and post-treatment. On the right are the objective displacement measurements. You can see her lips have retracted, and her chin has moved forward. Compared to the conventional 2D photos, with this method, we can clearly identify the difference. how to calculate the displacement objectively. It is very important to first determine the head position. I set the reference coordinates as shown in the lower left. The ICP technique was then used to superimpose the pre- and post-treatment images. Especially for the T-zone, we try to keep it within the plus minus 0.25 millimeter. Eventually, the head position was adjusted precisely. Let me add something about the ICP technique. The ICP algorithm is a classical method for the rigid relation. It repeats this search for the corresponding points and estimates transformation so that the distance between the corresponding point and the target point is kept at the lowest. I will show how we apply the ICP technique clinically. Please allow me to quote our article. It was published in 2010. The clinical base was used as a reference area for the ICP superimposition. After that, we get the frontal view. You can see the matching level as well. We can change the reference area depending on the part we want to observe, like in this 2D superimposition. We have reported on the effect of the Schwartz appliance using the ICP technique in the AJODO and angle orthodontics over 10 years ago. Now, let's dive into today's final topic. For the answer to the second question I mentioned earlier, the phenomenon of the facial rounding, how often does it happen? Before that, I have one hypothesis. The rotation of the mandibular plane may affect the frontal view of the face. In this way, typical cases confirmed our hypothesis. Now I want to go back to my second question. In this regard, I would like to introduce two articles we can refer to. Homologous modeling is frequently adopted as a new quantitative evaluation method of this field. In this study, the homologous modeling technique, principal component analysis are used to determine the sex difference from the homologous, morphology change of the mandible. Here is the second article. After converting the 3D model of the object into a homologous model, PCA was performed, which allowed visual confirmation of the result. The homologous modeling technique and PCA are used for the evaluation of the facial soft tissue changes. A significant difference between the straight face and the posed smile was observed in the PC2, the second principal component, and PC4. This time, by using the homologous modeling technique, an attempt was made to reveal the changes in facial appearance that were caused by the vertical control. This slide briefly explains the material and methods of this study. We studied 18 Japanese adult females. The age range was 23 to 39. We treated them with 4 premolar extractions. In total, 36 DICOM data were used. This was approved by the Ethics Committee of Okayama University. We divided these 18 patients into 3 groups and evaluated them based on their pretreatment FMA values. One angle was maintained, one decreased, and one increased, both by around 2 degrees. For example, 33 degrees becomes 31 degrees. 3D data is made up of the polygons. The total number depends on each data point, making statistical processing hard. When we use the common template data with a fixed number of the polygons to each data point and match it with the set landmarks, we can create a model with the same number of the polygons. This is the homologous modeling technology. We converted the STL into the OBJ data using the landmark coordinates and the template models. We generated homologous models. And then status processing could be performed. Please recall this hypothesis. We evaluated following the three groups. First, 6 average cases with maintained FMA using the treatment. Using the homologous modeling technique and PCA, we could get the result on the next slide. The contribution of the most important principal component was 30%. 1 to 5 PCs explained over 83% of the total variance. A significant difference between the pre and post was observed in the PC4 and 5. We created a scatter diagram of the PCs that influence the categories and helped us check whether the separation had been achieved. In the PC4, changes in the morphology of the mentalists were confirmed due to the retraction of the protrusive maxilla. In the PC5, changes were confirmed in the change degree of the maxillary protrusion. By using the following three methods, ROC curve, scatter diagram, animation, the principal components that influence the separation of the two categories, pre and post treatment, and then check whether the separation has been achieved. Next, 6 high-angle cases with reduced FMA. I will show you the result on the next slide. The contribution of the most important principal component was 32%. We were able to explain over 87% of the facial changes with 1 to 5 pieces. ROC curve and chi-square tests were performed, and significant difference between the pre and post were observed in the PC3 and 5. AUC helped us to find that PC5 has the strongest influence. Please allow me to add about PC5 here. Morphological changes were confirmed in the lateral and frontal view, especially lower facial area. Finally, low 6 angle cases with increased FMA. I will show you the result on the next slide as well. The contribution of the most important principal component was 27%. 1 to 6 pieces explained over 87% of the total variance. A significant difference between the pre and post was observed PC2 and 4. Here we get animation just as before. In the PC2, changes in the morphology made us notice facial slimming and retracted protrusive lips. In the PC4, changes were confirmed in facial slimming. I will explain later how to express the difference from the PC2 more objectively. I mentioned earlier, ROC curve and scatter diagram and animation of the PCs allowed a visual confirmation of the result. Additionally, factor loadings are visualized even more precisely with which part of the face are correlated this point is very different from the three methods above. To visually interpret highly correlating the vertices surface zone with loading values greater than 0.5 were colored with X, Y, and Z direction. At this loading value threshold, PC2 and 4 were correlated with the facial streaming. This is the X-axis. And PC5 was retracted lips in blue. This is the Z-axis. We can see the difference directly. Research conclusion. In this number one, in the three groups, the retraction of the protrusive upper and lower lips and the changes in the morphology of the mentalis were observed. Number two, although the sample size is too small to adequately evaluate this hypothesis, it was possible to observe the changes in frontal facial morphology associated with the changes in FML. Similar evaluation is possible with a 3D camera. Judging from the present results, it is suggested that if changes in the facial outline are observed during the treatment, vertical changes may have taken place. In other words, the 3D camera could be an optional tool, just like a lateral cell. Summary, we found that by using the homologous modeling to evaluate the morphological changes of the facial soft tissue pre- and post-treatment, the characteristics of the conventional 2D could be demonstrated. Number two, in addition, comparison of the four premolar extraction classified with the FMA suggests that the vertical control may change the frontal view. Number three, it seems that the method of the 3D quantitative evaluation of the facial soft tissue morphology using the homologous modeling technique can be added to a new evaluation method in orthodontics. Thank you very much for your kind attention.
Thank you for the great presentation. Are there any questions? I do have one. The 3D camera you use, what company is it from?
I have several type of the camera. So mainly little too nervous.
Just to follow up, is it like, with all those type of cameras, do you feel the similar results when analyzing?
No, different. I have several rounds, so I check the difference. So now I've detected what is the with the difference. Or so it's kind of the depend on the company. Several there is some feature. Depend on the company.
Oh, okay.
Yeah.
Okay. Well, so if there's no more questions, thank you very much for the great presentation, and this concludes the session for today.